Good morning, everyone. Thank you guys for coming. Second last Friday academic meeting. I just want to say thank you to Jared for organizing our program. And next year, we're going to have an even more adventurous, exciting program with lots of interactions between management as well and more valuable life and practical cases and talks. And thank you guys for coming. Nice to see familiar faces. So we've expanded our reg program to Donald Gordon Medical Center, and we've put some registrars there now. And I had the honor and privilege of having Preyanka as my first registrar. And she comes with a solid research background that showed a lot of limitations and deficiencies in me. So we had this very interesting case that didn't make sense to us. And the purpose of her presenting this case is because we learned so much about it. And if you fight for your patient and you think about patient, and this is all science, fighting for patients, you can actually offer patients good quality care and not just write off patients. So it would a humble thing, I actually called Preyanka to come and give her talk.
Hi, so I'm one of the registrars. I'm presenting a case supervised by Professor Mohammed in the GIT unit at Donald Gordon. It's titled Bumpy Ride. Okay, so this patient is a 15-year-old Black African female with a 2-year history of jaundice and pruritus and loss of weight of 4 kgs over 2 weeks. She has a past medical history of atopic dermatitis since childhood, but no family history of liver disease or autoimmune disease. And she presented repeatedly for the past 2 years with this complaint of jaundice. So on examination, she was well looking with a GCS of 15 out of 15, with jaundice, pallor, and scratch marks, and inguinal lymphadenopathy. There were multiple, but soft, non-tender, and 0.5 by 0.5 centimeters on average, with the tender right upper quadrant and the tip of the spleen felt. But besides that, no other features of chronic liver disease, no ascites, and the other systems are normal. So her blood investigations revealed a pancytopenia with the HB of 9.3, platelets of 118, and white cell count of 2.84. And then also a mixed pattern of liver derangement with a reversed AST-ALT ratio and conjugated hyperbilirubinemia. The albumin was low at 28, but INR was normal at 1.1. And importantly, the AFP was elevated at 165,297. Her IgG was elevated at 54.8, suggestive of autoimmune hepatitis, but the screen was negative except for an elevated Preyanka. Hepatitis screen was negative. Just X-ray was normal. The CT abdomen showed a solid mass in the left lobe of the liver, 8.6 by 6 centimeters. And the liver was decreased in size and force density, suggestive of cirrhosis. There was extensive lymph nodes in the abdomen. The spleen was bulky with a length of 12 centimeters, and the veins and vessels were normal. So because of the deranged liver function, liver biopsy was performed, and it showed features of malignant hepatocytes with immunohistochemistry positive for alpha-fetoprotein with a background of heavy lymphocytes and plasma cells. So the conclusion was features of hepatocellular carcinoma and a background of cirrhosis secondary to autoimmune hepatitis. Because of the diagnosis of the hepatocellular carcinoma, a staging PET scan was performed, which showed bilateral neck lymph nodes, axillary lymph nodes, intrathoracic nodes, nodes in the abdomen and pelvis as found on CT, and also bilateral inguinal and femoral nodes. So this is important to take into consideration for the follow-up of this patient. So the conclusion of the PET showed features of primary HCC with a background of liver cirrhosis and intra-abdominal and intrathoracic nodal mets. But because of the neck lymph nodes, the second neoplastic process couldn't be excluded because it's not typical for hepatocellular carcinoma. Upper and lower scope was done to complete the workup, which showed small varices, and the C-scope was normal. So if we just review the case now. So the important points that the patient had was autoimmune hepatitis, cirrhosis, hepatocellular carcinoma. So autoimmune hepatitis, it's a chronic disease of unknown cause. with inflammation resulting in cirrhosis and liver failure, more common in females and a bimodal distribution. And importantly, that Black African patients present at an earlier age with more aggressive disease and progression to cirrhosis. And it commonly presents features of hepatitis, such as jaundice and hepatomegaly. So the investigations to diagnose is a biopsy, and then antibodies depending on the type of autoimmune hepatitis, type 1 anti-smooth muscle and ANA, and type 2 anti-liver kidney microsomal. But in 20%, the antibodies can be negative. And IgG is a response to treatment and also to assess liver function. Importantly, it's associated with other autoimmune conditions like primary sclerosing cholangitis and primary biliary cirrhosis. And the treatments are corticosteroids and azathioprine, depending on the response, with liver transplant for acute liver failure and decompensated cirrhosis. And then hepatocellular carcinoma, it's the most common primary malignancy of the liver and the third leading cause of cancer death, most common in Asia and Africa, most likely due to the increased prevalence of risk factors for cirrhosis. More common in males and increasing onset with age, but in Africa it's been shown like at a younger age, like 40 years average age of diagnosis. This is important to consider that in only less than 10% hepatocellular carcinoma occurs in a normal liver, so we need to look for any underlying causes of cirrhosis. Alpha-fetoprotein can be elevated in 75% of cases, but in some cases it can be normal. And if you have a patient with cirrhosis, they should have 6 monthly ultrasounds plus minus an AFP for screening for early detection, because early detection is important to have good outcomes in terms of treatment, because treatment is based on staging. So the prognosis, overall, the survival is poor, with a 5-year survival of 18.4%, and by stage it worsens, so 32.6 in localized, 10.8 in regional, and 2.4 in distant disease. And the outcomes are influenced both by the features of the tumor, the underlying liver disease control, and the patient's functional status. But the important thing to note is that early diagnosis is critical to provide effective treatment. So the staging of hepatocellular carcinoma, there's many different staging criteria, but this is the one that's most commonly used because it predicts outcomes more effectively. So if you have advanced stage disease, which is nodal mets or distant mets, then your survival is less than 10% in 3 years. And the treatment is mainly supportive. But if you have early or intermediate stage, then you can look and think about curative treatments like liver transplant or radiofrequency ablation. And the 5-year survival is greater than 75% in transplant patients, with recurrence as low as 15% at 5 years. So since the management and prognosis depends on the stage, it's important for us to discuss the lymph nodes and lymphatic drainage, because our patient had lymph nodes throughout. So the lymphatic drainage of hepatocellular carcinoma or the liver in general, there's deep and superficial drainage systems. The deep system will involve the hepatic nodes, celiac nodes, and posterior mediastinal or lumbar nodes, if they are involved. And then the superficial system, you'll get involvement of hepatic nodes, lumbar, parasternal, or pericardiac nodes, and then celiac and superior mesenteric in the abdomen. So this is just a picture of the nodes that would be involved. So hepatic and celiac. And then you only get, besides that, mediastinal nodes. But that's a rare thing in hepatocellular carcinoma, with only like up to 5% of patients having metastasis to those nodes. So the important thing for us is our patient had mediastinal nodes, which is rare, but she also had cervical, axillary, inguinal, and femoral nodes, which doesn't fit the lymphatic drainage of hepatocellular carcinoma. So because of that, a mediastinal lymph node biopsy was performed, and it showed benign lymphoid tissue with no evidence of metastatic malignancy and reactive changes. And then an inguinal lymph node biopsy was performed, which showed extensive histiocytes and melanin pigment, but no metastatic malignancy. So those features were in keeping with reactive dermatopathic lymphadenitis. So up to this now, this biopsies are confirming that there's no metastasis, just dermatopathic lymphadenitis. So dermatopathic lymphadenitis is benign lymphatic hyperplasia associated with atopic dermatitis, and it's a T-cell mediated response to cutaneous antigen stimulation. It commonly involves the inguinal and axillary lymph nodes and generalized lymphadenopathy less commonly. But in up to 50% of patients, there'll be no underlying dermatological condition, and they may be associated with autoimmune disease and presence of antibodies, which increases the risk for this lymphadenitis. So because of this, a final diagnosis was made of localized hepatocellular carcinoma on a background of cirrhosis, secondary to autoimmune hepatitis with portal hypertension, and dermatopathic lymphadenitis secondary to either atopic dermatitis, which she's had since childhood, or autoimmune hepatitis, which is now presenting as generalized lymph nodes. So we're suggesting that this dermatopathic lymphadenitis is mimicking metastatic hepatocellular carcinoma. So if we now review her stage, she was initially an advanced stage with a less than 10% survival after 3 years. But now with this new diagnosis of dermatopathic lymphadenitis, she'll be at least an intermediate stage, and then to think of possible, at least start thinking of possible curative options if they would be available. So the management of her up to date, on the last time I've seen her, she was given steroids for autoimmune hepatitis and thinking about possible approaches for this hepatocellular carcinoma that she had, thinking of curative directions. But if the lymphadenopathy wasn't worked up and she was just assessed as metastatic hepatocellular carcinoma, then we would have not been thinking of any curative approaches. The disease would have progressed. She had been given chemotherapy and supportive management, and there would have been a poor prognosis for survival, and she's only 15 years old. And then if you look back, she had a 2-year history of jaundice, and she presented multiple times to primary healthcare facilities. So the early diagnosis of autoimmune hepatitis and appropriate referral would have probably resulted in earlier diagnosis and prevented cirrhosis, or at least resulted in surveillance for hepatocellular carcinoma with early detection and better treatment options. So the learning points from this talk is, if you go back to the title of the presentation, it's a bumpy ride, which is both because of the extensive lymph nodes and because it wasn't a straightforward case. So the important things is to always correlate your clinical signs with the diagnosis and pathophysiology of the disease that you're thinking of. And if it's not adding up, then to go back and review and consult a multidisciplinary team for appropriate management. And that thorough history, examination, and investigations will impact your diagnosis, management, and survival, and also to appropriately refer and ask for help if a patient is presenting with a long-standing issue and not progressing or improving. So these are the references just to review.